Hello, I'm Dr. Chris Thomson, plastic and reconstructive surgeon. The following represents a basic hand exam video for entry-level learners. Start your hand exam with inspection. Look for lesions, lacerations, discoloration, atrophy, swelling, erythema, and the distribution of sweat on the hand. Nerve injury can cause a lack of sweating to the area that the nerve innervates. Look for areas that appear dry compared to the rest of the hand. Don't forget to assess the nails for nail changes, like pitting or Bowes lines. Conduct a screening sensation exam by using light touch bilaterally and asking the patient if the light touch feels normal and symmetric. Assess the ulnar, median, and radial nerve individually. The median nerve is tested by lightly touching the volar aspect of the index finger or thumb. Test the ulnar nerve by lightly touching the patient's little finger. Lightly touch the web space between the thumb and index finger on the dorsal side of the hand to assess the radial nerve. Next, check capillary refill on the volar aspect of the digits. Capillary refill should be less than 3 seconds. The modified Allen's test is a test of arterial competency and collateral circulation. The radial and ulnar arteries form two palmar arches in the hand, the superficial palmar arch and deep palmar arch. In some individuals, the palmar arches are incomplete, meaning that they are ulnar or radial artery dependent for circulation to the hand. This is important to establish for procedures where compromise of one of the arteries can have devastating consequences. Now watch again as I explain how to do the test. Start by occluding the radial and ulnar artery simultaneously. Then ask the patient to make a fist until their hand turns pale, and then relax their hand. Then release the pressure of one artery. The hand should flush and become pink within 5 to 15 seconds. You can see that this patient is slower to fill through the ulnar artery on the left hand. Now check the motor function of the hand. We will start with the intrinsic muscles. The intrinsic muscles have their origins within the hand itself. There is no radial innervation of the intrinsic muscles. Remember to test bilaterally and apply resistance so you can grade strength. The thenar muscles include the abductor pollicis brevis, opponens pollicis, and flexor pollicis brevis. Assess the strength of the thenar muscles by asking the patient to abduct their thumb and hold against resistance. All of these muscles have median innervation. To test the interosseous muscles, have the patient abduct their fingers and check strength. Conversely, you can palpate the muscle below the second MCP joint as the patient abducts the index finger as shown. Interosseous muscles are comprised of the palmar interosseous, which adduct the fingers, and the dorsal interosseous, which abduct the fingers. Generally, only abduction of the fingers is tested. The interosseous muscles are all innervated by the ulnar nerve. Froment's test is used to assess for injury to the ulnar nerve through its innervation of the adductor pollicis. Ask the patient to forcibly grasp a piece of paper between their thumb and radial side of the index finger as shown. Try to pull the paper out. The patient in this video has a negative Froment sign. This means the ulnar nerve is intact. Now watch as I demonstrate a positive Froment sign. The muscle I am pointing to is the adductor pollicis. If your ulnar nerve is intact, you will have a negative Froment sign. If it is not intact, you cheat by using your thumb flexors, which have median innervation. The extrinsics are the muscles that have their origins in the forearm. Injuries of the forearm can affect the motor function of the hand through damage to the muscle or tendon itself or to the nerves that innervate them. They can be divided into the flexors and extensors. We will first examine the flexors. Flexor digitorum profundus, or FDP, flexes the DIP joint. To test the FDP, block the PIP joint in extension, then ask the patient to bend the tip of their finger, or DIP joint. Flexor digitorum superficialis, or FDS, flexes the PIP joint. Hold the rest of the fingers in extension at the DIP joint and ask the patient to flex at the PIP joint. Note that approximately 7% of the general population is lacking FDS in the little finger unilaterally and 6% bilaterally. Flexor pollicis longus, or FPL, bends the thumb at the IP joint. Flexor carpi radialis, or FCR, and flexor carpi ulnaris, or FCU, are the flexors of the wrist. We will now move on to the extensors. Extensor pollicis longus, or EPL, extends the IP joint of the thumb. The best way to test this muscle is to have the patient place their hand on a flat surface and then instruct them to lift their thumb off the table. Extensor digitorum communis, or EDC, extends the MCP joints of the fingers. Note that 30 to 50% of people are missing EDC to the little finger. Extensor indicis proprius, or EIP, and extensor digiti minimi, or EDM, extend the MCP joints of the index and little finger, respectively. To test EIP and EDM, ask the patient to extend the index or little finger while keeping the rest of the fingers in a fist. Extensor carpi radialis longus and brevis and extensor carpi ulnaris extend and deviate the wrist to their respective sides. Thank you for taking the time to watch this video on hand exam. Hand exam is a topic that is common amongst all medical specialties and also a topic that medical learners frequently say they are uncomfortable with. I hope this video has been of use to you. Best of luck in your future learning.